Hello and welcome to the final part of this respiratory revision crash course guide. Today we're going to be taking a look at the lung defense mechanisms and how we protect ourselves from pathology of the respiratory system. We're also going to be taking a look at homeostasis and histology of separate specimens with regards to the respiratory system. Finally, we will take a look at what happens to our respiration in unusual places, and this includes altitude, diving, but also the impacts of exercise and pregnancy on our respiratory system. So let's start with lung defense mechanisms. There are three main mechanisms we have in our airways to prevent lung pathology. So these are mucociliary escalator and airway surface liquid, the cough reflex, and also the innate and adaptive immune defense, which of course is generally applicable, the innate and adaptive immune defense, to pretty much all systems of the body in our immune response. But of course, cough reflex and mucociliary escalator are very specific to the respiratory system. So when these kind of things can go wrong, it can cause cystic fibrosis and other airway pathophysiology. If you imagine what goes wrong with cystic fibrosis in terms of the gene defect with regards to the transmembrane protein going wrong, essentially it's all about the buildup of mucus, and you can understand how this happens if the mucociliary escalator or the airway surface liquid or the cough reflex even isn't working as well as it should do. So mucociliary escalator essentially looks a little bit like this. And you have a base layer here of cilia, and then we have a layer of sol and gel. And essentially the sol is the lower layer, which is made up of the liquid, and the gel layer, which is on top, is made up of mucins. So this is the airway surface liquid, and altogether it should be about 7 micrometers altogether. And we aim to keep it around this level in order for it to be adequate function. In terms of innate and adaptive response, we have alveolar macrophages, which are derived, of course, from circulating monocytes. All macrophages are derived from monocytes, but alveolar macrophages are very specific to the respiratory system, and they hang around to dispose of dead cells, cell debris, particulate matter, and any invading microorganisms, and they do this by phagocytosis. In terms of immune surveillance, this is before mounting an adaptive response. So an adaptive response is much more efficient, but it takes a lot longer to kick in. The immune response in general is covered in the foundation block videos, so if you're having any troubles with this, please do refer back to those to get a good explanation of the cellular and humoral aspects of the innate and adaptive immune system and how they differ. So moving on to homeostasis then. Homeostasis is really important in the respiratory system, but it also links into other systems as well. So remember, the brain controls the respiratory rate through signals from our medulla oblongata, and it signals to our diaphragm and other respiratory muscles to contract. So remember, we've got other areas of the brain that are involved as well. So you've got the pons, and this regulates the medulla. Essentially, you've got an apnoistic centre, which controls the gasp, and the pneumataxic centre, which is all about fine-tuning of the respiratory system. You've got the cortex, which can voluntarily override pretty much a majority of these aspects, because essentially it's you controlling what you want to do with your breathing. And you've got the hypothalamus, which is in control of our emotional breathing. Next, we have chemoreceptors, and these are located centrally, which detect changes in the H+ level in the CSF. So normally, if you think about it, CO2 diffuses into our cerebrospinal fluid. The CO2 then transforms into bicarbonate and hydrogen, and of course that hydrogen can be detected by the central chemoreceptors. This one not particularly relevant right now, but what are important are the aortic and the carotid chemoreceptors, which detect changes in the partial pressure of oxygen and CO2 in the system. And obviously noticing falls in O2 or retention of CO2 can cause the brain therefore to regulate a response appropriately, essentially, to change the levels of O2 and CO2 in a variety of mechanisms, which are probably too in-depth, I'd say, for first year learning, but obviously as you go on, secondly, it's probably quite important to be aware of how they occur. So next we can think about shifts that occur in the respiratory system, and there are 3 of these to be aware of. So first of all, you've got the hamburger shift or the chloride shift, and this essentially is where bicarbonate is exchanged for chloride ions, and this maintains the electrical balance in red blood cells and plasma. The next one is an interesting concept, and it's the Boer effect, and it's possibly something you learnt back at A level. Essentially, it's where hydrogen ions cause hemoglobin bound to oxygen to give up the oxygen. So think about hydrogen ions. That's essentially saying you've got increased acidity. So what's happening here is hemoglobin's oxygen binding affinity, in other words, how much it wants for oxygen, is inversely related to both acidity and the concentration of CO2. So therefore, if carbon dioxide reacts with water to form carbonic acid, an increase in CO2 causes a decrease in blood pH. and as a result then your hemoglobin releases its load of oxygen. On the other hand, a decrease in carbon dioxide would cause an increase in pH, and if you've got an increase in pH, the hemoglobin is going to have a higher affinity for oxygen and more likely to bind to it. In terms of a Haldane effect, this is where CO2 binds better to hemoglobin with a hydrogen attached rather than to hemoglobin with already 2 oxygen molecules attached. Another aspect of shifting to be aware of is the oxygen saturation curve. So essentially this is a curve that you'll probably be familiar with. Basically, as your partial pressure of oxygen increases, so does the saturation up until a certain point where it's going to level off, because the oxygen is pretty much the hemoglobin is pretty much as saturated with oxygen as it possibly can be. A right shift in this curve essentially would be as a result of increase in CO2, decrease in pH, an increase in temperature, those kind of things. And essentially, if the curve shifts to the right hand side, that causes a decreased affinity of hemoglobin for oxygen. It's less readily binding to oxygen. If it shifts to the left hand side, on the other hand, this increases hemoglobin's affinity for oxygen. It wants to bind to more oxygen, and it can bind to a maximum of 4 oxygen molecules. And an interesting concept about hemoglobin is essentially the more molecules of oxygen it becomes saturated with, the easier it is for it to bind to another oxygen molecule. And it's also useful to be aware in regards to fetal hemoglobin curves, it would be shifted to the left. And therefore this is because in fetal hemoglobin it differs from adult hemoglobin in respect it has a higher affinity for oxygen, which gives the developing fetus better access essentially to oxygen from the mother's bloodstream. Now the reason for this is explained by the lack of the fetal hemoglobin's interaction with this 2,3-DPG or 2,3-BPG. So in adult red blood cells, this substance decreases the affinity of hemoglobin for oxygen. So 2,3-BPG is also present in fetal red blood cells, but it interacts less efficiently with the fetal hemoglobin than it does with the adult hemoglobin, essentially. In terms of histology now, very quickly, but it's really important, I guess. So start at the top with trachea and the main bronchus. These aspects are very similar in their main layers, so they have a mucosa on the outside, submucosa, and an adventitia as you work in. So have a look here, this is of course the lumen. Then you have the mucosa, submucosa, and adventitia. So if you imagine this is a circular lumen here, and then this is the surrounding tissue essentially. So the adventitia is the outside layer, the mucosa is the inner layer touching onto the lumen. So zoom in a little bit more onto the mucosa. Well, the mucosa is made up of both the epithelium and the lamina propria. And if we have a look at the epithelium, essentially what we can see are a pseudostratified epithelium, so a fakely stratified almost epithelium. It gives the impression it's stratified as in layered, but it's not really. Essentially is the derivative of pseudo, so pseudo's fake stratified epithelium. These are the cilia, of course, present on the epithelium, and then you've got the basement membrane and the goblet cell, so goblet cell, mucus secreting cell. Zoom in on the submucosa, so the next layer outwards. So the submucosa is made up of loose connective tissue and serous and mucus glands. So this is what your submucosa would look like, and this is connective tissue. These are fat cells, so characteristic appearance, very almost look hollow, if you wish, on histology, very white in comparison to the pink surrounding structures. This is an artery appearing more red. General histology techniques are think about, well, an artery is going to appear in this kind of red colour. Fat cells appear very similar to this. A lot of the time it's a fairly good rule to follow, I would say. Mucus glands as well look a little bit like this. Histology is fairly hard, but I guess if you kind of get to grips with some basic ones, and the more you look at them, actually, the easier they become to interpret. And this on the outside here is the cartilage. If we have a look at the adventitia, that outermost layer is the most prominent layer, and it's got dense connective tissue, smooth muscle, and hyaline cartilage. So here we can see the cartilage. As we've said, this is a blood vessel. It's stark red. It's screaming at you that it's a blood vessel. And then as you go down here, you've got muscle fibre. If you go further down the chain, of course, we've been through the trachea now, we're moving in towards the alveoli and the bronchus. This is an alveoli, so this is from a out bit. I mean, if you can guess what this is, it's a blood vessel because it's bright red. It's screaming at you. And this is the bronchus, so the main impeding bronchus, and you've got all these alveoli here. And of course, they're well perfused if you think about it. So you've got capillaries coming in here. If we really do zoom in on the alveoli, you can see these air spaces, and you can see almost the walls of the air spaces as well. So this, of course, is the alveolar space in which the gas is coming in. This is a capillary, again appearing nice, bright and red. This is the alveolar wall, slightly more pink in presentation, a bit thinner as well, so made up of type 1 pneumocytes. So that's pretty much all the histology you really need to know for a respiratory system. Just focus on those main three layers, the submucosa, mucosa and adventitia. And hopefully, and also the alveoli, I guess, as well, is really important. Just be able to identify where they are and some of the basic features of the histology. So a few unusual situations now. So if you're climbing, of course, as you increase, you very commonly hear of people with altitude sickness. And essentially, this is not as a result of a change in composition of air. You still have the same amount of oxygen, nitrogen, etc. in the air as you do at 5,000 feet, at 25,000 feet. But the partial pressures of the constituents all fall with the decreasing barometric pressure during the ascent. Essentially, the fall in partial pressure reduces the partial pressure gradient, which normally drives O2 uptake, and therefore causes hypoxia, aka altitude sickness, really. Moving on, you've got diving, and diving can be quite complicated, but let's think about it logically. Essentially, external hydrostatic pressure increases with increased depth. In other words, there's more pressure the lower you go, and water therefore squeezes and compresses the body from all sides. And essentially, if it's compressing the body, it's compressing the gas which is in our alveoli. And if you compress a gas within a certain volume, essentially you're increasing its partial pressure, and this relates back to one of the laws we were looking at earlier. Essentially, at sea level, only oxygen and carbon dioxide can dissolve in the blood to a significant extent, but diving increases the partial pressure of all the gases. So essentially, nitrogen is the one we need to worry about, because nitrogen can have significant narcotic effects on our body, because at depths of 40 meters or more, it can dissolve into the cell membranes and affect our ion channel function. When it does this, essentially, it can cause serious problems, and it can cause narcotic effects, as we've said, similar to those of ethanol. Essentially, divers who work down at depths usually use heliox, which is a mix of helium and oxygen, and they use helium instead of nitrogen because it dissolves in the body less readily, and essentially it's less narcotic and less dense than nitrogen as well. The bends is a clinical condition, essentially, due to divers ascending too quickly, and essentially you can overcome this by slowly ascending. But essentially what happens are nitrogen bubbles block the blood vessels, and obviously this can lead to significant conditions, but can easily be reversed with hyperbaric treatment if it's detected, i.e. what's gone wrong with this patient, why are they so unwell. So next we can look at some physiological conditions which exacerbate the respiratory system. So for example, in terms of exercise, the more exercise we do, the greater the demand of the muscle cell for oxygen, and therefore our heart rate is going to increase, our respiratory rate is going to increase, and in order to increase the amount of gaseous exchange taking place, in order to thoroughly oxygenate those tissues that require more oxygen. In terms of pregnancy, again, physiological, but obviously it changes respiration, our ribs flare outwards, the diaphragm moves upwards, tidal volume increases overall, but respiratory rate importantly doesn't change. The end result essentially is an increase in minute ventilation and a decrease in CO2 partial pressure. As a result, we then have a compensatory decrease in bicarbonate ions as well, in order to keep that pH in its standard range between 7.35 and 7.45. In terms of summary, I'm not going to go through these questions because I did go through them at the beginning. Fairly simple questions in terms of what doesn't pass through the diaphragm, phrenic nerve being responsible for innervating the diaphragm, and an understanding with regards to spirometry with that FVC, FEV1. What can you ascertain? Well, it's not the residual volume. You cannot measure that through spirometry. So two harder MCQs now, just to round everything off. What is the role of surfactant? Is it to decrease pulmonary compliance? Is it produced by type 1 pneumocytes to line the alveoli? Is it increased lung surface tension or reduced lung surface tension? So when you have a question like this, if you've got increase and reduce of the same thing, it's likely that one of them is going to be correct. And here we need to reduce lung surface tension in the role of surfactant. Be aware it's produced by type 2 pneumocytes and it increases pulmonary compliance. One more harder MCQ, so then in the diagram, which letter is correct anatomically and with the correct linked function? So is B a red blood cell that transports mainly carbon dioxide? Is C an arterial capillary that passes oxygen to tissues? Is A the alveolar cavity, which is the main site for gaseous exchange? Or is it D, which is the capillary wall where oxygen and CO2 are exchanged? Please do pause the video at this point, try and have a think about it, and hopefully you'll come up with the answer that A is indeed the alveolar cavity, and essentially it is the main site for gaseous exchange across this permeable membrane here. That's everything for these videos. If you do have any feedback, please do let me know, and I hope you found it useful to review the anatomy and physiology of the respiratory system. Thank you very much for listening.